So he have ventilated him, and over a period of 1 day to 2 days, he developed sudden hypotension, and his fundus was papilledema, and even though he is in his conscious level is deteriorating, and he has some electrolyte imbalance. And the next case is a second post-op day. Mother who has lactated properly the first day or the second day. On the third day, she develops a failure of lactation, along with some electrolyte imbalance and severe acute headache. And the third case is a case of pituitary macroadenoma, who has presented you with a sudden onset of headache along with an ophthalmoplegia as well as papilledema. What do you think? Something is associated with the pituitary. So this pituitary apoplexy can present with the three main. So the pituitary, being a master gland of all the glands, can present to the emergency can present as an pituitary apoplexy, which means that it is a constellation of signs and symptoms where the whole of the glands function is affected. It may be caused by sudden hemorrhage or infarction of the same. It usually it usually occurs in postpartum or in a pre-existing macroadenoma. So what happens is that it is a medical as well as a neurosurgical emergencies. So previously we had the surgery was not that very important because skull is a volume constrained space, and due to and that too the pituitary fossa has a much more volume constrained space. You have to have a multidisciplinary approach in dealing with any kind of pituitary apoplexy. The most common cause of pituitary apoplexy or pituitary hemorrhage is going to be spontaneous hemorrhage into the pituitary fossa. Apart from that, pregnancy, radiation, trauma, these are the things, autoimmune disorders, these are the things that can cause pituitary apoplexy. Apart from that, surgery, any stress, any major surgeries in the intracranial region can produce this pituitary apoplexy. Now, main pathophysiology is not only the loss of function of the gland, but also due to this pathology, the surrounding structures are also getting affected, which means that your aortic chiasma get affected, and the cavernous sinus along with the 3, 4, 6 cranial nerves also will get affected. So you have to look for these signs when you are suspecting any pituitary apoplexy. So the clinical presentation will be a retroorbital sudden development of severe headache, and like a thunderclap headache. Of course, subarachnoid hemorrhage is another important differential diagnosis for this pituitary apoplexy, and there will be visual loss with diplopia and ophthalmoplegia, and also increased intracranial features like nausea, vomiting, and altered consciousness. There will be also features of acute adrenal insufficiency. So the patient may go in for sudden development of shock in spite of having a proper fluid resuscitation. The patient may go in for shock, and meningism may mimic subarachnoid hemorrhage. The patient may have meningism. So this is what I was talking about. Anything that is going to affect your pituitary fossa, it is going to have a cascading effect of the structure surrounding the pituitary fossa, namely your aortic chiasma and other cavernous sinus and other 3, 4, 6 cranial nerves. So as I said, the diagnosis is mainly based on clinical suspicion. So only you can confirm with an MRI or a CT brain where you can find a hemorrhage or an infarction inside the pituitary fossa, and MRI will be more helpful because these evaluation of hormones will take much more time. So your clinical suspicion along with this radiological investigations may or it will confirm the diagnosis of pituitary apoplexy. So definitely you have to rule out subarachnoid hemorrhage. We can rule out with the radiological investigations. So you can look out the pituitary hemorrhage in the T1 images. It is visible over the arrow, near the arrow. So it is such a small space. You can see in the arrow for the undergraduates, you can see the corpus callosum, this pituitary hemorrhage, apart from the midbrain and the pons and the medulla. So anything, it is the cavernous will be in the coronal section, coronal section model. Sorry. So coronal section you'll be having the cavernous sinuses, so easily it can affect the other structures. So Sheehan syndrome, the main thing is failure of lactation. Previously, lactating mother, she will develop failure of lactation along with dehydration as well as shock. And one important point for postgraduate is you have to differentiate between Sheehan syndrome and lymphocytic histiocytosis. So the one important thing is Sheehan syndrome is usually it will be associated with pregnancy, and this lymphocytic hypophysitis it will be associated with autoimmune disorders. And another important catchy point is about the hormone deficiencies. While corticotropins and thyrotropins will be much more deficient in lymphocytic hypophysitis rather than Sheehan's. In Sheehan's, it will be always the sex hormones as well as the somatotrophs, the gonadal growth hormones, that will be very affected. So in a pituitary MRI, there will be empty cella, while in lymphocytic hypophysitis, there will be a pituitary mass over there. So these are the three more major differentiating points between an Sheehan syndrome and lymphocytic hypophysitis. So emergency management, as everybody told before, steroids as well as fluid resuscitation seems to be the initial management of any pituitary apoplexy. Of course, to relieve the pressure symptoms, you have to go for neurosurgical procedures. And hypoglycemia, that also you have to take care. So what about prognosis and follow-up? They have a very good prognosis. I mean, visual recovery if treated uh, early, recognizing the condition. And also the pituitary function will recover in 30 to 50%. And of course, you can put them on hormone replacement. Long-term follow-up should be done with MRI, visual fields, and endocrine assessment. And fortunately, the recurrence is rare if it is managed appropriately. So key takeaways are pituitary apoplexy. It is an acute hemorrhage or infarction of the pituitary. You always suspect in a case of acute headache with ophthalmoplegia. Apart from cavus sinus thrombosis, you can suspect subarachnoid hemorrhage and pituitary apoplexy. And it treat as an endocrine emergency. Start IV steroids along with fluid resuscitation immediately. And you have an early neurosurgical consultation so that you can relieve the compressive symptoms and save the remaining pair of the pituitary gland. And multidisciplinary approach improves the outcome. Thank you. So most of you have finished your puzzles, I think so. அப்படிதானே இருட்டா இருக்கனால எழுத முடியலையா லைட் போட்டுக்கோங்க